My name is Raju Balakrishnan. It is my distinct honor to serve as the Dean of the College of Business at the University of Michigan-Dearborn, and I would like to be the first to welcome you all to the first event of the 2016-2017 College of Business Executive Speaker Series panel. Today's topic is how healthcare has changed the business environment. This event begins our 6th year of what has become a signature event not only for the College of Business, but for the entire University of Michigan-Dearborn. Each event of this series has grown in size and popularity as evidenced by the large crowd here today. I think we are off to a great start for the 2016-2017 year. At the outset, I would like to thank DFCU Financial for sponsoring today's event. Brian has given me only 2 minutes, so it kind of gives me no time at all to brag a little bit about the college. But I do hope for those of you who are visiting here today, you'll take a few minutes to look around the college, because we have phenomenal faculty, staff, and of course, fantastic students, a lot of whom are represented here today. So I'm just going to move on straight to saying a few words about today's topic. The US spends more on healthcare than any other country in the world, but yet we complain more about healthcare in this country than any other country in the world. The total cost of healthcare in the US was about $75 billion, that's billion with a B, in the 1970s. In 2009, when the Affordable Health Care Act was passed, US healthcare cost was $2.5 trillion, that's trillion with a T. A PwC estimate predicts an increase of 6.5% just for 2017 alone. By the end of the decade, it is estimated that healthcare will cost $4.8 trillion each year, which is about 20% of the US total GNP. That's a pretty big number. Today's topic, therefore, has a dramatic effect on each of us, not only with regards to our pocketbooks, but also as the foundation to our quality of life. The healthcare environment continues to face new challenges, changing how we gain access to healthcare, as well as its cost to businesses and individuals. While some have argued for a single-payer system controlled by the federal government, others claim it is the cause for underemployment, rising costs to business and their employees, and the rationing of healthcare resources. The purpose of this event is to remove some of the political hype and discuss the current healthcare environment, its successes, its challenges, and recommendations to improve the system. The future direction of healthcare will also be discussed, focusing on its effects on businesses, individuals, and the overall economy. Again, I think we are off to a great start for this year's Executive Speaker Series. We have 3 very distinguished panelists here today, and I look forward to a lively discussion. At this time, I want to once again acknowledge the financial sponsorship provided by DFCU Financial and invite Michael Kruchek, Chief Lending Officer from DFCU Financial, to say a few words. Michael?
Good morning, everyone. It's a pleasure for us to be here, and we're very proud to sponsor the business series. You know, as a credit union that began 66 years ago in Dearborn with the entrepreneurial spirit of 7 Ford engineers, DFCU Financial understands how the small ideas and dreams of a few can change the lives of many. We are now up to over 200,000 members, and we have 28 branches statewide. DFCU has a long history of supporting education and other initiatives about which our members and community feel very strongly. Being the Business Speaker Series sponsor for U of M Dearborn is one of these commitments that we value greatly. This university's impact on education, business, and entrepreneurism is key to the success of the city, the region, and the state. This speaker series spotlights relevant topics that impact the small and larger business owners and students alike. Regardless of whether you're in the business program here or from a small or large company, we're all affected by the current healthcare law and how it influences our business customers, especially in the areas of cost, quality, and availability. We welcome this panel's insight and recommendations for improvement. Thank you for letting us be a part of this conversation today and future conversations that will impact our community. Thank you.
Good morning. Welcome to the event. Yeah, healthcare cost. I'm at the end of my career, so it's not going to hit me as big as the majority of the audience looking at the students. So luckily, you'll be paying for my stuff. We have three really good panelists here, and I just want to do little introductions for them. First is Robert Casello. He's Regional President and CEO of St. Joseph Mercy Health Systems from Southeast Michigan. And that organization is quite large. They have 5 hospitals, including one in where I live, 6 cancer centers, and if you look at the employment they do, 2,700 physicians and 12,000 other employees. That's quite a large organization. One of the things that Rob does, and we talked about because we both bike, although he does on-road biking, I do real biking off-road, but he's founder and captain of Team Joe's cycling team, and they do some on-road races, including a 3-day one, I think 300 miles, 100 miles a day. He invited me to, but I said 29er's not going to do that. So he joined St. Joe Mercy in 2008. He's prior president of Providence Park Hospital. He's also a board chair for the Make-A-Wish Foundation, past president of the Michigan Hospital Association board also. I'd also like to introduce Rick O'Donnell. Rick got his undergrad degree in psychology and a graduate degree in public health from the University of Michigan. So he's a Go Blue person, definitely. He was employed by one of the first HMOs in the country, definitely in our state. Basically, it turned eventually into Blue Care Network. December 8th, he joined Trinity Health, and then in 2012, he started heading up provider contracting and reimbursement division for Priority Health. His wife, Alice, is a registered nurse, so she is also in the medical area. They have 3 adult children, none of which want anything to do with the healthcare industry. Last but not least is Dan Wakeman. First of all, Dan is a longtime supporter of our university, especially the College of Business. And when we started the speaker series, one of the first events we had was on healthcare. This was before the Affordable Care Act was even written. And they discussed ways to reduce healthcare costs and what national experts thought would reduce healthcare costs, none of which went into the Affordable Care Act. But Dan's been with us for a long time, and we'd like to talk duck hunting too. He's currently president and CEO of St. Luke's Hospital in Ohio. He started there in 2008. After 20 years of hospital experience here in Michigan, he has a bachelor's degree, like I said, from us in business administration here at Michigan-Dearborn. He also has his master's from Central Michigan University, which we have something in common because we both have a master's from CMU. His wife, Jasmine, is a retired RN. Their son, Chris, is a faculty member at Central Michigan University. His daughter, Lauren, works with special needs as a special needs teacher in Ingham County. And I'd like to welcome the panel. Okay, guys, here we go. First question. And just a general question to start us out. 2016, this year, will finally kick in majority of the Affordable Care Act, and actually by 2018, we'll have the complete Affordable Care Act in place. What are the elements of the current U.S. healthcare system that actually works well? I mean, we talk about all the things of it doesn't work well, but what does work well? What has been successes with the ACA? Go ahead.
Well, happy to start. Good morning, everyone. Glad to be with you. So I know we're going to talk about ACA, and I love the title today, How Healthcare Has Changed the Business Environment. I hope by the end we might actually flip that around, talk a little bit about how the business environment's actually changing healthcare. Because ACA, as a law, is one of many laws that have been passed going back 7 decades, the Hill-Burton Act, and this industry that we're in has been chasing legislation for 70 years and designing itself around legislation. And I think right now we're in an era finally where healthcare is subject to the same economic laws that many other industries have been facing for many years. And that's consumerism and all that. So the ACA gets all the attention, takes up a lot of oxygen. I don't like to discount it, but I will tell you I don't wake up every morning wondering what the ACA is going to do to my organization, because it's really the economics of what's happening to consumers and to businesses that are shaping this industry. The ACA, I don't think, has delivered on the promise that its founders had intended because of the way that it got rolled out and some of the things that happened and didn't happen. It was supposed to create access, and access has improved. If we look at the number of people who are insured now versus before, it's definitely gone up. Has it gone up as much as the creators intended? No, because a lot of states did not expand Medicaid. Some of that access did not get created. So it's been unevenly probably rolled out in our country in terms of access. The cost equation, I will tell you right now that I think that's we're going to see 5-6% increases again. We're definitely still outpacing general inflation, so we are still ahead of the curve, and that means we're going to continue to consume too much of our nation's economy. Now, in general, and I'll stop in saying that, is our health system working well? We're the highest cost per capita health system in the world, and we're ranked 34th in the world in health. I'm an outcomes guy. That is not a system that's working. It may work in pockets, it may work in certain communities, it may work for certain individuals, but as a whole, in my estimation, it's not working well.
A generation ago, the Clinton administration was an ardent proponent of what became simply known as the Clinton Plan. And as Rob said, for decades we've been trying to legislate healthcare and legislate the reforms of healthcare. The Clinton Plan went down in flames. Subsequently, the administration was able to put through piecemeal bits and pieces of healthcare. I don't call it healthcare reform, I call it healthcare insurance reform. Too often we limit it to just calling it healthcare reform. Now we're at the point with the Obama administration where it was a question of doing something or doing nothing. And I personally felt it was the right thing to do something. And as Rob said, the way it got rolled out and the way the sausage was made was not pretty. The compromises that were made were debatable. But something did get legislated, did get implemented, and I think now is systemic. Very difficult to unscramble the eggs once they've been scrambled. I want to make a distinction, though, between coverage and access. I agree with Rob that the ACA has improved healthcare coverage. We have managed to stack, if you will, coverage for Americans from basic Medicaid to expanded Medicaid coverage in many states, because it's a state decision, to the exchange, subsidized insurance, to employer-sponsored insurance, to Medicare. So all these different programs interfacing along the socioeconomic continuum, we've been able to really enhance coverage. What we really haven't done with the ACA, though, is figure out how to resolve the question of access. We told people, we're going to give you coverage, we're going to give you a card. Good luck finding a primary care provider who has capacity, who can take you in and create an ongoing relationship with you and your dependents. So access, I think, is the unresolved issue around the ACA, whereas coverage, I think we have done a magnificent job of providing more coverage
to more people than historically.
Boy, after following these two guys, there's not much to say because they really summarized it very well. I think Rob's observation of saying the ACA was the major catalyst is really incorrect. The major catalyst was the unsustainable economic model in this country of spending 20% of the GDP on healthcare comparatively to the nations throughout the world who we're competing with in a worldwide economy. That's what's really changing things. The reality is this country can't afford the Medicare system as it stands right now and has to be changed. And the way it has to be changed is that we're going to add value to healthcare and not just volume. We were a high volume business for years, which causes the access problem that was just discussed because we're paid on a piecemeal basis, not an outcomes basis. And what you're seeing right now is both insurance companies and the government moving quickly to change the entire economic model to an outcome basis. But it's a huge shift for people. I often say when you look at other industries such as banking or auto as they adjusted to the worldwide economy and things such as value, we're going down that same pathway. We're just starting at 30 years too late. And not to be mean to the university people, but I think you're the next ones in line for some what I call pretty significant changes in what's called the revenue that we're putting up for the value you're producing. And, you know, for the most part, being U of M, Dearborn, I think it's a great product, but in a lot of organizations, there's a big discussion as how much longer can we support the higher education, just like how much longer can we support a Medicare system that is in no way economically sustainable in the long term. That's the big change. That's the big change agent. The ACA wasn't. So I agree with everything the other two guys said.
Okay, so we'll start with Dan because you ended up with last that time.
Oh, thanks.
But what we'd like to talk about a little bit is a little more about where we need to make improvement. What has gone wrong, and are there ways to fix it? What direction do we need to go in? So, you know, some of the parts work with coverage, but what doesn't work that affects businesses and individuals that we can get a fix for?
Well, to start off, and what we're seeing really hit the, what I call news wires today, the media, is in the ACA, the economic premise of the exchange product. Those individuals who didn't have insurance either through their employer or through a government-sponsored program would go to the exchange. But what they found out when they put this out there is those states that did have Medicaid expansion, that a significant amount of individuals actually qualified for the Medicaid expansion program instead of the exchange product. And that was usually a younger, healthier population that was now qualifying for the Medicaid products instead of going into the exchanges. And who ended up in the exchanges, as we were talking about earlier, I said it's my retired employees. When we did an early retirement plan in 2013, we had 150 people take us up on that because that was just when the ACA was being laid out. They saw the exchange insurance product being a very reasonably cost alternative to the employer supplying them insurance. So they took their early retirement and went on the exchange. What the insurance companies, and he'll explain it to you, is that's not a good actuarial model because everybody that went into the insurance plans were 50-something up who used more health care, and all the people they assumed who were going to go in the 20s to 30s did not. They went into Medicaid. So the insurance model is collapsing on itself at this point in time, and there's all sorts of what I call solutions people are trying to find right now. But typically what you're finding with what I call the very large insurers, they're just saying, I'm not going to deal with it, I'm dropping out. And so that's an area that needs to be fixed. Some way, actuarially, we have to figure out a way to move maybe some of that Medicaid population into it, or in the exchange product itself, somehow what I would call combine it or stir it into other products so the risk pool is greater so the insurance companies can carry the risk.
About 10 years ago, I was working at the time for Spectrum Health in Grand Rapids, which is the parent company for Priority Health. And my boss, who was the CFO, before Spectrum, and we were at a meeting, and he was talking about the concept of defined benefit versus defined contribution for retirement plans. So historically, widespread, the norm had been throughout multiple industries of a defined benefit for retirement, as opposed to the employer making a defined contribution over a longitudinal period, and that becomes the employee's nest egg upon retirement. And the CFO was talking about it in the context of healthcare companies, particularly hospital and healthcare systems. And at the time he said to me, 1 out of 3 hospitals, this is just 10 years ago, 1 out of 3 hospitals is doing this, defined contribution. The rest are defined benefit for retirement. And I said to him naively, well, heck, that'll never catch on. That's a huge change for employees. It's going to cause widespread dissension. It's going to be tough for the uptake. Well, today, I don't have the stats for you, but I can tell you it's the norm now, 10 short years later, for retirement plans to be defined contribution, not defined benefit. Where am I going with this? Let's look at healthcare. Let's look at healthcare benefits, the next horizon, the next frontier. And I think that the ACA, I think there was a not so subtle intent to encourage, to incentivize, to move employers, particularly small group employers who have less than 50 employees, which is the backbone of our economy, by the way, by far and away. The intent was to move those employers to a defined contribution model rather than defined benefits. Rather than coming to Priority Health and buying our coverage and paying a premium, they would give a specific fixed amount of money to the employees and say, go out on the exchange and find the plan that best suits your needs. Be a consumer. Buy according to the thought process that a consumer would use when you have a fixed amount of money and you go out and buy car insurance, life insurance, house insurance. So what I think that it's debatable whether this is where it ought to go, but I think that's where the ACA was intended to go. It hasn't had that impact. It hasn't had that effect. We're still in a defined benefits mode, not defined contribution. But if employers wanted to make a radical change and have, I think, a meaningful impact on their cost, they would move to that model.
So I might take a little different tact on answering this question. But one thing that Rick is pointing out here is that as employers change their plans or change how they treat their employees in terms of how much they make them pay or maybe giving them a set amount, the theme is that risk is moving to the individual. That everyone in this room will be making decisions that have a financial impact in healthcare for sure and in other arenas as well. And as risk moves to the individual in this marketplace, thus changes the industry. And if you look at our industry and what really needs to change, they can make the tweaks that will likely happen to the ACA, whether it's repealed or replaced or tweaked, whatever, something will have to happen, I imagine. I think it'll have very little impact on the root cause. The root causes of where we are today in cost and quality and access, as Rick pointed out. And it's really a fundamental change that's going to happen inside the industry, and it's going to be driven by the consumers. Right now, we're upside down in terms of how we're configured. And I'm going to use the autos as a great analogy because when we went through that recession, I'll use the example Ford Motor Company in the shadow here. At the time that they were making a decision on their future and whether to take bankruptcy or not, they were shutting down fixed capacity wildly. Plants were shutting down across. At the same time, billions going into product development. Because what they realized is that they still needed to create a product people wanted to buy. And they had to invest and contract at the same time. In healthcare, and being a large provider of what I'll call sick care services or acute care, I would tell you that we sell a product nobody wants to buy. Rick doesn't want to pay for it as an insurance company, and you don't want to pay out of pocket for it. You want to stay out of the hospitals as far away from that because, one, it takes you away from your life, and secondly, it's very expensive. Yet we have huge fixed costs in this industry invested over years in exactly the product you don't want to buy. So as we're reconfiguring to sell you the product you want to buy, and that's preventative health and wellness and all those kind of measures, we still have this huge albatross of fixed cost that we have to deal with. So we're going to have to contract and invest at the same time. That is not the ACA, folks. That is nothing to do with legislation. That is laws of economics. And so what's got to change is a reconfiguration, which we're starting to see. And there's way too many hospitals. We have excess capacity in this country, and that's going to be very painful to wring out over time.
One of the things we're looking at in this equation is we have a provider side of healthcare and we have a consumer side of healthcare. The dean already mentioned the PwC study with the 4.8 trillion, I almost said billion, 4.8 trillion by the end of the decade. From the provider viewpoint, those involved in that market, whether it's insurance, whether it's hospitals, whether it's the pharmaceutical companies, what on that side of the equation, what other things on that side of the equation can help us at least slow down the rise of healthcare costs?
Give it a whirl.
It's Rick's turn.
From a provider perspective, and I will take that perspective because I spent 15 years representing providers before going to the dark side and representing a payer. But I think one of the things that drives the numbers behind the PwC study is the fact that the United States uniquely is the early adopter of medical technology. A lot of that technology is developed and designed and researched and developed in Europe, but it's not adopted in Europe. The U.S. is the early adopter of medical technology. We try to find a way to use it. We love gizmos and gadgets as an industry because we believe that the outcomes are going to justify that higher cost. And so we implement that technology, not necessarily always in the most efficient manner. And then as we work through the proper way to adopt and implement the technology in conjunction with healthcare treatment, that becomes more normalized. Costs start to fall. And then I think as that technology becomes more normalized, more mainstream, that cost then is more affordable in other countries, other economies. And so I'm not saying it's the right thing to do. I'm not saying it's the wrong thing to do. It's what's driving a lot of that cost is our propensity for embracing high-cost technology, but getting the cart before the horse and not necessarily knowing when is how to best implement and adopt those innovations. So I'll leave it at that.
Well, if you ever notice that when price of gas goes down, all the pickups start selling really well, and when the price goes up, they can't sell the Ford F-150s. You ever notice that? Healthcare is a lot like that in a way. We have a system that's perfectly designed for the health that it's treating. And what I mean by that is the demand being created on the systems is sometimes determined by the health of the population that we're serving. So if you really want to change something, the underlying health of our communities is so poor in terms of any rates you want to look at, obesity rates, hypertension rates, diabetes rates, all feeding on one another. And this is, I think we're underestimating the runway that we're looking at here in terms of what this is going to cause downstream in terms of demands. And then, as Rick is saying, and he's completely right, we jump straight from prevention to the highest tech and most expensive interventions because of that. You know, we miss a whole space in between of treating chronic disease efficiently, of keeping people healthy. It's really we're well, we're getting sicker, we don't know it, and then we crater, and then we're into these very high and expensive things. We have And it gets down to social determinants of health and all this, and this is not political, this is business. When you have a population that is not eating well, doesn't have access to food, doesn't have good mental health services, when you have that bloating in any country, in any economy, that's going to pop out somewhere, and it's going to pop out on the end of the cost of care in treating those individuals. So this isn't an overnight solution, but the long-term solution is no matter what we do short-term, if we don't get our arms around this issue as communities and country, no matter what we try to do in healthcare to solve the cost issue, we're going to be treating so much disease, it's going to be very, very difficult to keep the costs down. So right now, I don't see a check on this increase until we find solutions to those issues.
And I think the debate on that will be back to what both have talked about, how much more of that responsibility of your health comes out of your pocket. It's amazing when you have to pay more for it, you might not eat that double eggs, ham, cheese, egg McMuffin, and you might go for the fruit over there on the table, okay? Let me take what they just talked about and give you a real life incident. In 1985, I was the supply chain director for capital buying for the Detroit Medical Center. We were building a new hospital out in northwest Oakland County called Huron Valley. And at the time, we figured demographically there was a massive amount of what we call fat and 40s out there. Fat and 40s were people in their mid-40s who have a horrible diet, who eat a lot of fatty foods, who end up needing gallbladder surgery. So we ended up putting a whole wing on that hospital, 35 beds, to do nothing but put fat and 40s after they get their gallbladders out into those beds for a 3-day stay. What ended up happening is the fat and 40s didn't disappear. But in between planning that hospital, putting that wing together, people started to figure out that I can take these gallbladders out with the thing called a laparoscope. I don't need to cut them up their belly. I can go in with just a couple of little pokes and a scope, and I can actually grab that gallbladder and pull it out. And they can go home the same day. It's outpatient surgery. So what we did was we invested that capital in that building that he was just talking about, all those beds, staffed it up. Never got more than 6 or 7 patients on that floor, yet we still were doing all the gallbladders. We were doing with the technology he just talked about. And so what we do is we chase the dollar, whether the dollar's coming from the insurance company or anything else, and what we like to chase it with is technology. In my hospital right now, I'm battling with 2 of the payers, and he would like this one, on urogynecology services. I have a urogynecologist who can go through your belly button, take out your uterus, and string your bladder up in about 1 hour and 45 minutes with that robot, and you're going home 12 hours later. That surgery used to take about 4 hours in the OR and used to be a 4-day to 5-day stay for younger, healthier women. Now here's the kicker. I used to get paid about $22,000 to $23,000 from the insurance company for doing that. Now on an outpatient basis, they're only paying me $8,100. I'm going, holy smokes, and that damn robot cost $2 million. So now I want to go back to him and say, hey, you, insurer, I'm giving you a great deal now. I just dropped that cost massively with my new technology. And he's saying, that's your problem, Dan. Figure out how you're going to squeeze the cost out, make it work. And the whole point here is that we do chase that technology. We are a country that believes I should get everything right now when I ask for it. It better be damn good. Where other parts of the country, or other parts of the world, access isn't an issue. And that they don't think that way. As Americans, our culture is, I want everything right now and it damn well very good. Let me pull up my phone and get an app for that, okay? Other parts of the world, it doesn't work that way. So there is a cultural change that has to shift and market demands in order to bring this cost structure down. And the government giving some assistance getting us there with the ACA is it. But I think overall market conditions and the economy is really going to push it.
So I'm oversimplifying this, but to connect some dots to what Dan is saying, how is he going to pay for that robot? He's going to pay for it by hiking the price of a simple chest x-ray.
Yep.
Or a panel of lab tests.
You
right?
got it. That's exactly what we're going to do.
So he has to defray that cost somehow, and it's going to go across the rest of his delivery system and misrepresent the underlying true cost of those services because it's a business necessity.
And he's worked on both sides, so he knows exactly what our strategy is going to be.
For the, well, actually all the business students, you had that managerial cost. They talked about fixed and variable costs, the managerial course. This is what they're talking about, spreading that fixed cost around. 6 years ago, Dan, you brought up a reaction from your wife of the cost of something in healthcare, and the idea of having skin in the game causes your behavior to change. Mm-hmm. So now I want to, with that comment, with that thought from 6 years ago, I want to come back to the consumers of healthcare, whether it's the business organization or the individual, and look at the business, especially from the business organizational viewpoint. What can they do to contribute to a reduction in healthcare? That side of the equation, the users of healthcare.
Well, the users is defined by the difference between users and buyers or payers. The users, the individuals, and we've stressed it at this table all through, the more skin you have in the game, the more you have to pay out of your pocket, the better consumer you become very quickly. And I often get in this argument with some of my friends who are since retired and also came from this university, and they'll go, yeah, but we're too stupid to know how to buy health care. And I go, you who just investigated buying a new flat screen TV for almost 3 weeks on the internet to find out the best deal, you tell me you can't go out and shop the best deal for laboratory services in town? Come on. It's out there. You just never been taught to do it or thought about it, or you never had an incentive to do it. And one of the things we saw, and it was prior to ACA, especially where I'm at in the Toledo market area, was the economy was already going down the dumper in 2007, before 2008. The employers, we had one of those Ford plants shut down that Rob talked about right away. A lot of people were losing their jobs. So what the employers started doing at that time is going to very high deductible, high copay plans very quickly. And the reason why is they didn't have to worry about what I call competing for labor, because there was a huge labor glut in the marketplace because of the economy. And all of a sudden you start seeing people becoming very engaged in shopping price, especially in what I call those low-end, not acuity, low acuity deliverables, the MRI, the CT, the nuclear medicine test, the laboratory test, and they become much better shoppers on the area. But where we really need the help at this point in time, in my opinion, is I'd like to see the employers get better engaged in that area, because what we're seeing is employers still buying what I call product for access. I will go with Michigan Blue Cross and Blue Shield because every hospital and every doctor's in it. Well, the reality is that might not be the most economically wise plan for you to go for in your company. Your company may be much wiser in looking at a priority health type of alternative, maybe less cost to you. Plus, Priority really does design their plans to add value back to the employer and the employee. And so what's really important, in my opinion, is that when you look at what I call the price of healthcare, the best way to force down price is to put a very competitive market out there, and we're not there yet. We still have a ton of government subsidy, which will be around, a ton of employer subsidy, but back to the defined contribution, it's interesting when you go out to states out west that do go defined contribution for health care. And they'll tell the employee, I will pay $18,000 for your total knee. If you decide to go to a hospital that does it for more than $18,000, out of your pocket, Charlie. You're paying for the difference. Well, I want to go to University of Texas to have it done. Then good. It's $26,000 a year. You're paying the differential. Or if you're really smart, you can go to the community hospital down the street, which has great outcomes on total knees, and they do it for $16,000. And you just not only went below your point, but you left more money in your HSA for the long term for other things you may need. Those are consumer decisions, and that's how that cost is going to be brought down.
You know, I use an expression at work sometimes. It's nothing clears the mind like a lack of options, right? So we have an unsustainable amount of healthcare consuming our gross domestic product. Now, the only qualifier I'll say on that is that healthcare is a huge employer, so a lot of that cost ends up back in the economy through incomes. Mm-hmm. But having said that, it's still too much. You can, as individuals, afford to take 25% of your net income and dedicate it to healthcare and pay for everything else you want to do in your life. So something's got to give. So the question is, what can individuals or users do? Well, one, I think Dan touched on it, be a smart consumer. There is options and available lower cost options. Rick and I were talking about one beforehand, about you go out for physical therapy, there's costs from A to Z on physical therapy and be a smart consumer. A lot of times you get directed to places. Well, be your own director and take your own accountability for health care. The other is, as you're making choices with employers, if you move to designs that put more maybe opportunity for coverage on prevention, but more risk on you for higher end care, more copay, more deductible, it's going to force a behavior in yourself, isn't it? You know that if you have something hanging out there, you're going to make changes to make sure that you don't get sick and take care of yourself. I mean, things happen, we understand that, but there are a lot of the illness out there that's preventable. So it's personal accountability. You can lower your own cost of care. That translates down the road to those of us who provide it. So, the individual consumerism here is a key component to bringing some of these costs in control over time, in my opinion.
There is a danger with consumerism, and I'm an absolute ardent proponent of the concept, and Priority Health has been hammering away at this for about 5 years in how we design our benefit plans and some of the technology we've brought to the market to try to show comparable costs between various hospitals and other kinds of healthcare providers. But one observation is that it's irreversible. And for a geezer like me, looking back on my career, I never thought we would see consumerism be embraced the way it is today. I really wrote it off. I thought, we live in kind of a sort of a nanny state where employers are just too benevolent. Well, that has changed, and it's irreversible. There's no putting the genie back in the bottle. We have health savings accounts. We have high deductible health plans. We're going to be moving to defined contribution health policies. No question that that's where the market, I think, is going to take us. But the downside of that is there is a risk that consumers will then completely avoid necessary care. And they will push it off and delay it and defer it until they end up at Rob's emergency department or Dan's emergency department with a critical condition. And then what are we looking at in terms of cost? And it could have been avoidable cost. So we really need to work smart within benefit design, within employer policies, within governmental policies, to make sure that we're designing those benefits so that they are encouraging individuals to get care that is needed at the right time, so that we don't see a phenomenon where people are just avoiding and ignoring until such time as they've created a catastrophic situation.
Just to add one thing to Rick's point, because it's absolutely correct. The ultimate solution is don't seek care at all, right? And then we'll lower costs. I don't know if you paid attention when the states were all voting to expand Medicaid. I think 22 or so expanded Medicaid. Maybe it's more. Michigan was unusual in being a Republican state in the state legislature and governor and passing Medicaid expansion. But Governor Snyder at the time, and it goes back to an earlier point that Rick made about access, he wouldn't support Medicaid expansion. It wasn't a partisan issue for him. It was an access issue. He made us prove, the providers, and we did a research study through a chart, Center for Research and Healthcare and Transformation in Ann Arbor, to study the primary care access availability in the state of Michigan. And Governor Snyder looked at it and said, there is capacity, so I'll do this. But it was interesting that this legislature passed it. But what they did, unique to any other state, other than Indiana now looking at it, is that they have behavioral requirements. If you're going to get Medicaid, get added to Medicaid, you had to seek a primary care doctor. You had to see that primary care doctor. You actually have to intervene in the system. You couldn't just get your Medicaid card and hold it to go to the emergency room. You had to actually have behavioral requirements. So at least at that's a small example, but it's 600,000 plus people that had to seek care to avoid what Rick was saying. And other plan designs probably have that same requirement and have that potential.
One of the interesting things that I often talk about, people go back to your base economics and the concept of elasticity of demand. We're starting to see that now in healthcare. And if you're very sick and very ill, you have very little elasticity of demand on how you're going to spend your dollars. You'll show up to the emergency room if you're having a heart attack and not really worried about the price. You're worried about living. Although if you show up to the orthopedic surgeon third week of January with a sore knee and say, I want you to fix this, doc, and the orthopedic surgeon says, well, I'm not going to do anything until I get an MRI. And you say, well, how much is that going to cost, doc? And he said, what do you care? You got insurance. He says, my insurance deductibles just went up to $5,000, 50% copay on the first $5,000. He goes, wow. So how much for the MRI? $1,000. How much on my pocket? $500. You know what, doc? I'm not going to do anything right now. So for the next 8 months, I suffer through taking Motrin, putting ice on my knee, because I come back in November and I say, doc, I'm all ready. Let's get this knee fixed. Let's get the MRI done. Let's do it right now. And he says, why are you back now? What did you do for the last 6 or 8 months? And he said, I took Motrin and put ice on it, which now causes the bleeding ulcer because I've been taking Motrin for the last 6 months. And the doctor says, what the hell did you wait so long for? And he says, the reason why was because my copay and deductible was so high. He says, why are you back now and you're in such a hurry? Well, my wife just had an emergency hysterectomy and we blew right through our copay and deductible. So I got to get this done before the end of the year because my copay and deductible is less. And he says, you mean to tell me you went 6 months with that pain in your knee? He goes, doc, remember when I came in? He goes, no. He says, third week of January. He says, yeah, so? He says, well, next week's Super Bowl. And he says, what's that got to do with it? He says, all my buddies are coming over. We're going to at my house, big Super Bowl party, and my big screen TV sucks. So, new big screen TV, $512, $500 for the MRI. Which choose did I do? I took the flat screen TV. Elasticity of demand. I'll live with that sore knee for 6 months. You know what, healthcare? We never saw that before. Never saw that. First dollar coverage, my knee hurts, I'm coming in, doc, do an MRI, put some steroids in it, fix it with a quick scope. Now all of a sudden you see people actually delaying care for elasticity of demand. I've heard stories about women delaying hysterectomies for the trip to Disney World with the family. Okay, copay and deductibles. So all of a sudden, we're in an interesting era right now in healthcare. Price and elasticity of demand will be a big player.
We've talked a little about the ACA, and one of the things that's coming down the pipeline, well, there's a few things coming down the pipeline that could add additional cost that it won't kick in until the end of 2016 and between 2016 and 2018. First, what exactly is considered affordable health care? Okay. I know there's a government definition of it. Yeah. And second, what are some of the changes that are going to happen over the next 2 years with the Affordable Care Act that most people don't know about yet?
Well, I think one of the changes that you're referring to, Brian, is the fact that there is something called the employer mandate. It's pay or play. You have to provide coverage to your employees, or if you don't, this is oversimplifying, but if you don't, there are penalties, taxes that get imposed or levied on the employer. And some employers are more than happy to take that penalty because they can actually provide dollar, perhaps, allocations to their employees and say, go get your own coverage. But that is going to be, the rules around that are tightening up in 16, 17. The thing that got deferred was the so-called Cadillac Tax, which was supposed to be implemented, I think, in 2018. Now it's been moved back to 2020. So we don't have to worry about that. We're not even going to think about it. But I think that one of the things that we'll see is that more employers are going to have to be addressing the mandate, and there are fewer exemptions and fewer deferrals that can be taken by employers. What that will do is that will probably incur some expenses. Brian talked about affordable health plans. So the ACA legislation talks about the fact that an employer must provide, again, kind of simplifying it because that's the way I understand it, is that the employer has to cover essentially 60% of the healthcare costs of the beneficiary. And that, by the way, is the so-called bronze level of the insurance exchange. So the government set up the exchange with bronze, silver, gold, titanium, platinum, tellurium. But the bronze is the lowest, and that's 60% coverage, 40% out of pocket for an individual. Employers have to meet that minimum in order to avoid the tax or the penalty. And I think there are some other provisions around the out-of-pocket contribution that employees make, cannot exceed a certain percentage of household income. I think it might be 20%. Or 15% of household income, something like that. Maybe that's high.
Yeah, so affordable is kind of in the eyes of the beholder, right? So it kind of depends on what people can afford individually, but the individual mandate's also moving. So you have the employer mandate, but the individual mandate's going up. A lot of folks individually said, I'm not going to go on the exchange because I'll just take the penalty. Well, now when it goes to $695 or the greater of $695 or 2.5% of your modified gross income, it starts to become a big decision for individuals whether to take that penalty anymore. Well, if that moves people from taking the penalty to buying insurance, I can guarantee you it's going to be the lowest cost that they can find. And that means really high deductibles, probably $10,000, $12,000 deductibles. So I go back to pre-ACA, where we had a lot of uninsured in this country. And one of those uninsured walks into our hospital. They have an income, but they don't have enough to nearly pay that bill. And as a not-for-profit, we go through a financial analysis and we write off a piece of that bill, either all of it or a good part of it. So patient walks out, they're happy, they don't have the whole bill, but they have some financial responsibility. Take that same person now today, they have this insurance, it's still a $12,000 deductible. To me, it's no different. They're still coming in and they still have this big debt and they can't afford to pay it. And we go through the same financial analysis and we will end up writing off a piece of that bill. And so what will happen is the affordability, when you really look at pre and post ACA, it doesn't look a lot different to some individuals as they come into the places. They can't afford that deductible anymore than they could afford being uninsured. So it's going to be a little bit of some people are going to roll the dice on this one. I'm convinced. They're going to look at the penalty. They're going to say, well, maybe I'll just go for that really, Priority's got this great bronze plan. It's a couple $100 a month premium. Basically gives me preventative care. Everything else is basically on me up till a point. And I'm going to see how it goes, knowing that if I go to the hospital, I might at least get a break. Yeah. Does that make it more affordable for you? I think it stresses people out. And that's going to be, somehow we have to fundamentally change that, but that's what I predict will happen when these mandates change at the end of the year.
I guess my question would be too, who's going to be the facilitator of the affordable plans? As we see already in many of the exchanges and so on, that the insurers are just saying, I'm not going to play in that market. I'm not sure if people are going to be able to find the plans that are quote unquote affordable. Now, as was pointed out, a lot of the employers now may make the decision to buy a bare minimum plan for their employees as the requirement. But for those individuals that still have to buy their own plans and don't qualify for Medicaid, I think they're going to have a difficulty in finding a plan that really works for them, or who's going to be in that market for how long, for any type of stability. That concerns me a lot, and as he said, bad debt's bad debt. Whether you want to call it charity care or not, you're not getting paid. There's a significant amount of bad debt that we're starting to see now within the population, those high copay and deductible plans, and these people have no ability to pay that bill. So it's just like car insurance. You know what? Do you want to take a big risk and go with a $4,000 deductible on your car insurance? You'll find the premiums real low. But getting in an accident, you know what? First $4 grand's on you to fix that fender and windshield. So you're taking the risk. So I think what they said is very true. The other one, and boy, we'd be here for days if we talked about it in the next few years, the ACA changeover, is the reduction of disproportionate share, which really gets into the weeds, and we don't want to go there.
I know one of the things, I was reading the 100-page executive summary of the 7,000 plus pages of the bill, and it did talk about the Cadillac tax and the 40% excise tax for any plan above $27,500 for a benefit. So if you have an employer who has a really good plan for you, you end up paying an excise tax. Now, the difficulty with that And the same with the alternative minimum tax with our federal tax system, is that that's not inflation adjusted. And so eventually, you know, we're looking at that 2020 study. 2020, you're going to see a big bulk of the plans break that. And so it's going to be a boom in excise tax for a large portion of the population also.
Yeah, there's projection. Well, right now, if it was implemented today, I think I read it like a quarter of the companies would hit it already, 26%. If you don't inflate that threshold and you fast forward it now 4 more years at the rate of inflation, I don't know what they projected, but that number of 25% will grow tremendously over time unless they adjust it.
Just
right. So it's going to start hitting employers very, very hard if they don't figure out. That's probably going to be one of the footballs that the politicians are going to deal with as they tweak the ACA.
That'd be a big one.
Healthcare is a business also. How's the industry doing? We have a lot of players in it between the insurance companies, the pharmaceuticals, the actual healthcare providers, the doctors who are contracted in. I know in the news in the past couple of months, let's see, EpiPens, all of a sudden, which I have to buy. So for me personally, and then there's the insulin pens. Oh, I have those too. And the costs, we were looking at the cost of developing or manufacturing one of those insulin pens. 25 cents for production, $9 at market price for insulin inside. 5 pens a month, but that 5 pens a month are now going to be $18,000 per year. So the question is, how's the industry doing, and are there winners and losers in the industry? Or is it segment by region of country or company of the country? But who are the winners and losers right now out of all this?
I think the insurance plans, don't you?
Losers?
No, winners. And it is interesting to bring up the insurance plans because, and I don't know where Spectrum is or Trinity is in their model, but I was a part of the ProMedica system up until May when we lost the Supreme Court judgment on an FTC battle. But the reality is that system on the delivery of the sick care side is losing money. All the hospitals, the doctors' practices, and everything else. But the Medicaid product and their insurance is absolutely doing wonderful. And the reason why was there was that huge expansion of Medicaid in the state of Ohio, like Michigan. Actuarially, it was figured out on some older Medicaid data, which really didn't apply to all these young people who just went into Medicaid. And they're doing really well right now. Now, I think that's very short-lived. I think it's going to get corrected both by the state and by the federal government in the next 2 years. Back to your point about the drug companies, I go way back to my days in Sault Ste. Marie, Michigan, which was 15, 16 years ago. One of my board members said, why do you think drug expenses are so high? And at the time, I was really angry about our drug expenses going up at the hospital. And I said, George Bush just said something about axis of evil being South Korea, Iran, and Iraq. I said, it's not that. It's Pfizer, Merck, and Winthrop Labs. I said, because if you ever watch the movie Mission Impossible 2, did you guys ever see that one? The whole theme of the movie was the drug company actually created the virus, and they're the only ones that had the antivirus drug. And they found that out later, that they're the ones that actually created the virus, and they're the only ones that had the antivirus drug. I said, I'm not sure if that's so far from the truth, really, but...
That was Dan Wakeman saying that, okay? Not Rick O'Donnell, not Rob Castellou.
His name is spelled D-A-N.
Yeah, disgusting. And as we all go to our educational seminars with the physicians, they'll automatically always have to start off and say which drug companies are sponsoring all their trials. I'll just say none of the drug companies sponsor me, so...
I can't speak for the industry, the insurance industry. I'll talk about Priority Health, who I'm employed by and what I know best. Our well-being financially is not so dependent on the presence or absence of the ACA. We have embraced the ACA through expanded Medicaid coverage. We have a Medicaid program that has expanded as a result of the state of Michigan's decision to expand coverage for individuals. But our well-being really rises and falls on the economy in general. Mm-hmm. So you can look at our past 10-year financial performance, and where did we have great difficulty? like many of, well, most of the industries, 2009, 2010, and somewhat in 2011. But 11 started a real upturn. Had nothing to do with ACA. It had a lot to do with the fact that we are in the employer-sponsored health plan business, by and large. And then we also have a very large component of Medicare Advantage and now Medicaid. But, you know, and we shoot for, as a nonprofit, just as these gentlemen represent nonprofit companies, we shoot for a margin, operating margin, of between 2 to 3%. And we feel it's a really good year if we get 2.5. I'm going to contrast that with the for-profit insurance companies, Aetna, United, Cigna, the ones who have announced that they're pulling out of the exchange markets in Michigan. They have to bring home 6 to 8% margins for the shareholders. That's their mandate. They work under a very different dynamic than an organization like Priority Health, Spectrum Health. So I can just address it by saying that winners and losers, I don't think that we've been particularly advantaged or disadvantaged by the ACA. I think it's really the health of the employers overall. And if the ACA compromises the health of the financial health of the employers, well, then that will have an adversarial impact on us.
Before Rob goes on, I just want to do one pause here. You all have cards to write questions down. So if you have a question, write it down on the card, and our student assistants will pick it up and pass it to me, and then we'll have about 15 minutes of your questions. Go ahead, Rob.
It'd be a long conversation to go through segment by segment in the industry and say who are the winners and losers. In fact, there's winners and losers in each segment, so it doesn't help a lot. But a couple of general comments. One is, love to stand up here and beat up pharma for a while, but I won't go there other than to say this. Our pharmacy costs are the fastest growing expense in our system, not by a little, by a lot. 9% increase in our pharmacy costs on the same book of business year over year. Now, if you look back, nobody should be surprised by this. You know, a lot of this was predictable when the large pharma started buying up the generic companies. Yep. So the generics offered a low-cost alternative. They get purchased by the large pharma. What do you think's going to happen? So if everyone's here in shock and awe on this one, you know, you could have predicted this was going to happen. Now the question is, what do you do about that? When a pharma executive sits in front of Congress, having received a $30 million bonus and charging $600 for an EpiPen that costs her probably $20 to make, something is wrong. And I'm not one for government intervention, but I can guarantee you it's coming. So something will happen. So now I've gotten that off my chest. I had to get the pharma thing off my chest.
The hospital guys like to beat up on the pharmacists.
Yeah. But really, if you look at winners and losers, let's talk about Michigan for a minute. Michigan providers, and now I'm talking about health systems, were a big winner in the Medicaid expansion. In fact, if you look at 2015, the hospital margins in the state of Michigan went up substantially. Most of the health systems posted very healthy bottom lines. And Medicaid expansion was the largest component of that. And another dynamic occurred, and that is when more people went on Medicaid, the charity care dropped, but our bad debt didn't go up as much as we thought. So we had it all going for us. Now, looking at that, you may say, well, then, you know, something's got to give. If you guys are making too much money and we're paying the bill, the employers, the insurers, I absolutely convinced this is a temporary phenomenon because I don't think we've taken root yet with the behavior changes that will start occurring with the high deductible plans and everything we've already talked about. So I think the downward pressure on hospital margins is upon us. And at the same time, because utilization, the people, you know, even though I got through saying that people are still buying high tech and all that, there is a downward pressure on the high-end services. Yep. Our expenses continue to, you know, we're a large employer. We give wage increases. The pharma thing I already talked about. There's going to be an intersecting of these lines in the next couple of years where I think hospital margins are going to go back to either where they were or below in the next 2 to 3 years. And I'm absolutely convinced that's going to occur. So temporary winner, probably long-term, not so sure how that's going to work. And if you're really going to make an investment, if I was making investments right now, saying what's the future look like, well, look at the demographics. Look at continuing care, long-term care, outpatient care, anything that has to do with not a hospital. That's where I think the winner is going to be in the long term, because that's actually where it probably belongs in terms of appropriateness.
It's interesting, one of the things, and fully agree with what Rob just said, 15 was a banner year, 16 is not as sweet as 15 was. But one of the changes we saw in our marketplace is we have a pretty significant Medicare population right around us. And it's an interesting Medicare population in that it's a lot of elderly that moved into our area, into villas and what I call retirement communities, because it's in a nice area with a lot of lakes and so on. What's happened is the Medicare has changed part of the rules on long-term care facilities and how they pay long-term care facilities for high-skilled care. And what we used to see on a regular basis is what we used to call gingerly in the emergencies department the nursing home dump. And that is when the older patient in the nursing home in skilled care got into any type of trouble at all, they just quickly package them up, put them in the ambulance, and send them over to the hospital. And we put them on a med-surg floor, tune them up, as I would call it, and send them back. Well, the reality was is those nursing homes are being paid a much higher rate by Medicare for taking care of a sicker patient. What the federal government figured out through CMS is when that patient's sitting in my hospital, the nursing home's not taking care of them. So I'm not going to pay them the damn higher rate. So now all of a sudden the nursing homes are very wisely went out and hired a lot of nurse practitioners who actually manage those patients in the skilled nursing facilities, and they are not coming in from the skilled nursing facilities. So I have a standard, what I call lower acuity medical surgical unit that's already way underperforming any budget projections over the last 5 years. And that's just a little change, just our thing, and I now have excess capacity. And so when I go through the budget process next year, probably going to close that unit down. So.
Can I just add one thing quick, Brian? Piggybacking a little bit on what Rob was saying at the very end of his comments, he was kind of, I think, opining on where the puck is going and where some of the real hot activity is in this industry. And one piece I'd like to just toss out there, the real oncoming intersection of business and healthcare, I believe, is an area known as genomics. Mm-hmm. So hopefully some of you know genomics is essentially the science of determining, given the genetic type of an individual, how do you develop treatment regimens that can be most efficacious. And it's an emphasis on efficiency, so we're not taking individuals down rabbit holes for months and months with treatment, predominantly right now oncology, cancer care. But it's not only a matter of efficiency, it's a matter of, in the patient's best interest, of time and not wasting time while we're trying out different kinds of treatment regimens. So genomics, as an insurer, we're dealing with this on a daily basis, trying to figure out how do we import that technology, again, that word technology, but this is a technology I think that has a great potential for bringing efficiencies to the delivery of healthcare. And the last point, back to pharma, is that insurers, such as Priority, are working with companies to develop outcomes-based agreements. So if your product doesn't work, if your product's not effective with our patients, our members, you, the pharma provider, are going to have to rebate or refund a certain level of dollars. This is new precedent. This is kind of new territory, uncharted waters. But I think that's where we kind of have to go in order to ensure accountability of that segment of the industry.
A combined question from the audience. Are there other countries out there that are doing things in their medical systems that are good things, that are positive things that help control costs or help improve healthcare? And could some of those things they're doing be applied to help tweak the ACA?
So this gets into what countries and cultures and what kind of systems will work in various countries. Because if you look at the, quote, healthiest countries, those that have lowest disease prevalence and you know, basic health, community health indicators, the best in those, are generally, a lot of them would have single-payer, government-sponsored you know, systems. And a lot of people say that's rationing care. They lower their costs a lot of different ways. But I spent a little time looking at countries like Sweden, which is in that category, and others. And I'm going to go back to something I said earlier. They have basic underlying better health and better lifestyle. And I think that feeds the lower cost and the good indicators. And it actually makes their system easier to run and cheaper. So do we have a culture in this country, and do we have the right indicators to emulate some of those top, Norwegian countries, things like that? Even when we look north of us into Canada, who still suffers from some of the basic underlying health issues that we have, but they have a single payer system. They kind of depress utilization by I'm going to call it rationing, it's a bad term, but they have long waiting lists in some cases. Is that a solution? I'm not sure, but I know in healthier countries with lower costs, I think it's very easy for them to adopt a single system like that. I do think we should look at their countries in terms of not just their health system, though, but and why are there differences in underlying health? What is it about their cultures and everything that's different than ours that causes them to have lower obesity rates, higher activity, and those sorts of things?
So I was looking at a study by the Commonwealth Fund, and I'm a real name dropper, right? The Commonwealth Fund. No, I was looking at an article that came across my desk, study that was done on why the rest of industrialized world pays less for healthcare than the United States. And a big determinant of it was that, and it's kind of a chicken and egg thing. You touched on it in your very first comment today, Rob. Social determinants of health. Western Europe spends a lot of money on social services and social support. They spend less money on acute healthcare services. So if you can throttle back at all on some of maybe our excesses relative to less useful or dubious medical technology, maybe some of those dollars can be reallocated to social support to get at some of the underlying determinants of health status. I mean, it sounds pie in the sky, I recognize that, but it is a fixed pie. It's a fixed amount of dollars we have to work with, and based on our willingness as a society to pay, whether at the workplace or in our taxes. And within that fixed pie, then we have to determine how much of that gets allocated to medical care, how much goes to the social determinants piece and solving for that. And I think in Europe, that's probably where there's a better balance, and that's what's contributing to lower overall cost.
The interesting point that everybody seems to be making, which is it's really heavily culturally influenced. I was fortunate enough to be at a speaking session way back during the Hillary Clinton days back in '97, when we were all in healthcare deathly afraid of what healthcare reform would look like. And the speaker actually at the Grand Hotel, the MHA meeting, was Brian Mulroney. Brian Mulroney was the then sitting Prime Minister for Canada. And he talked about the difference between their system and the U.S. system. And one of his great lines that I thought was fascinating, he started off by saying, we're a lot alike. He says, we both like baseball a lot. We both like basketball. He says, we like hockey better than you do. He says, we both eat too much bacon and eggs and stuff. And we maybe smoke a little more than you do and drink more beer. And, he went through this whole social thing. We're so similar. He said, except for one thing. He says, Canadians do things a little differently. He says, for starters, every major corner you go up to doesn't have five fast food restaurants on it. He says, what you'll see is 2 or 3 restaurants, but they're all sit-down restaurants where people actually go in and sit down and eat. And they don't pack through 1,000 calories while they run through the drive-thru. But he said, here's the other big one. He says, the United States is probably the only country in the world that really believes that death is an option. He says, do you know how much money you spend on people in the last 2 years of their life comparatively to other places in the world? He says, you still believe that no matter what the cost is, you can stay alive. And what's sad is those of us who worked in the industry have seen that. I've seen 93-year-olds kept alive for 18, 19, 20 months, which should have really been let go because family and decisions weren't made. Now, I think we're changing a lot of that in our culture, but that's there. The other side was, similar enough, fortunate, when I went to this university, interestingly enough, I studied socialized healthcare back in the 70s in Europe, in both England and Sweden, with Marilyn Rosenthal, who was one of the sociology professors here. And culturally, what you found out very quickly, whether it was in England or Sweden, there was just a difference in the way they looked at things when it came down to social determinants of health. And a big part of it was the government's assistance. And we figured that out real quickly in both those countries when we wanted to buy a bottle of liquor over there. And it was like at the time $40, and here it was $12. So what the hell is it so expensive for? Well, they don't want people drinking over there. And if you thought about smoking, forget that. It was like $9 a pack back in the late 70s in Sweden. So the reality was they were already stepping in and changing the social determinants of health, not only from a social services perspective, but also from an overall taxation policy perspective. And that does have an impact on the overall cost of care. But I think one of the largest impacts, and we are now just starting to get our arms around it culturally and societally in the United States, is end of life and what is your health care plan. If you have a chronic disease and you're 81 years old and you've been on 4 meds for the last 7 years, who's going to sit down with you and have the heart-to-heart talk that, you know what, in the next couple of years your liver's going, your kidneys are going to go, you're going to start getting real sick. Do you want me putting you in and out of the ICU for the next 2 years for stays? Or do you want to go on palliative care at this point where I'll help you manage your signs and symptoms to keep you as active as you can, and you make the decision on when you're going to go with hospice? But stay out of the hospital, because you know what I'm going to do is I'm going to spend a lot of money and take your damn dignity away in the hospital.
Talked a little about end of life. It's some of the most highest costs of healthcare. And there's also a large portion of healthcare costs that is spent on a very small portion of the population. And you talked about the aging population. Other than the aging population, what about those with chronic diseases? How can we help better control costs in that area?
Let the insurance guy talk about it. You really are. You're doing a lot in that area.
Actually, it's not an insurance
Yep.
issue, and it's not a provider issue. It's a collaboration.
Yep.
We're seeing unprecedented levels of cooperation and collaboration between insurance plans, carriers such as Blue Cross, such as Priority, and the providers. We employ care managers. We employ an army of clinical people, MDs, DOs, RNs, advanced practice nurses, and they work with the infrastructure that exists in Rob's hospitals and with St. Luke's. They work with those individuals collaboratively to do case management, to do coordinated care. And this is burgeoning. I mean, this is within the last 5 to 8 years that we're seeing a much greater emphasis on this kind of activity. And we are moving care into the home, so we're encouraging home-based care for chronic patients. If we have patients who have, I think it's 4 or more diagnoses, chronic disease diagnoses, they qualify for in-home care, where a small army of clinicians and non-clinicians will provide that ongoing care in the home. Why? Keep that patient out of the hospital. Keep them out of the emergency department. And but the providers themselves are part of that team. They're providing, in some cases, they're providing the labor resources to do that. And that's just one example, would be in-home care. But there's a lot of examples of care management, collaboration. And I think we've got a better handle on this than we ever have for chronic disease management.
Yeah. I mean, the theme that Rick is talking about, I couldn't agree with more, and that is, go back 10 years, people with CHF, congestive heart failure, other conditions, would just bounce between home, nursing home, hospital. And taking resources and reaching them into the home, managing them there. And this is where technology can be a wonderful thing.
Yeah.
So we're using telehealth more and more to interface with patients and families in their homes, Skyping, things like that. Because the number one reason, by the way, a chronically ill patient will end up rebounding into the hospital is medication compliance.
Yep.
That they get off their meds, they're not eating properly, some kind of basic ADL stuff. So many admissions to the hospital are preventable. So these care managers that Rick's talking about, or even our own caregivers, getting on, talking, Skyping, working with family. We've been able to reduce that amount of admissions back into the hospital tremendously. We've got a long way to go. But this is where, you take technology and you leverage it to lower costs, and that's one example.
Back to the unit I talked about, we're going to probably close next year. The first thing we will offer all of our registered nurses is to be involved with the 2 or 3 home care companies we deal with that do manage those patients in home, because those are the patients that used to be on their floor. They're not on their floor anymore. They're in the nursing homes or they're in their homes, and they're being managed remotely with technology, but you still have to have the registered nurses checking up on them. So what we're going to do is try to facilitate them moving from that environment, inpatient, into where they're going to be adding more value to the system in that other way.
Well, I'd like to thank Dan, Rick, and Rob for being here today and contributing greatly for the panel. I'd also like to thank DFCU Financial for their support of this event, the student assistants, and there's also a couple of key people in the room that are just very important to making this event important. First of all, the person who does all the management of the registration and getting things out is Christine Dunning. Without her telling me where to go, I'd be lost. Adam, you're not getting out of this. Adam came on board this year and has greatly enhanced our marketing, and he also acts as a weekly sounding board for what's going on with this, and he has extensively contributed to the success of this program, as well as Michael back there. He's another sounding board person that I can always go to, and he has also offered great assistance for this group. I'd like to thank you. Our next event is how the future technology will change business. It's December 1st, same Thursday, and we're good. And for my students, I'll see you in class. For the rest of you, have a good day.